I am super excited about today because my guest, who you can see, for me it's down there, but maybe for you it's up there, I don't know, is Dr. Sunita Puri, who is the director of palliative medicine at USC and the author of the book, That Good Night. So I don't want to ramble too much because I want Sunita to have plenty of time to talk. But I will say that I was listening to your episode with Kate Bowler on Everything Happens, and I had to keep stopping it to be like, oh my gosh, I love these people so much. So one of the things that you talked about with Kate on her podcast was palliative care, and we're going to talk about what palliative care is. But one of the things that I loved in your description about what palliative care and palliative medicine is, you talked about domains of suffering and how palliative care teams walk alongside suffering and act as companions to pain that very often can't be fixed. So
exactly.
Let's talk about that. Could you share with folks what palliative care is and maybe what you mean by those domains of suffering?
Absolutely. So first of all, thank you so much for having me, Megan. This is such an honor to be in conversation with you. And to everybody out there listening, I hope that you are as well as can be in this time of such uncertainty and such high emotions. And I hope our conversation will help to give you some things to think about and know that you're not alone out there. So a lot of people don't know what palliative medicine means, including my own parents, which is kind of funny because you would think they would get it by now, but I think my dad still wonders, oh, you treat cancer pain? So we do, the very definition of palliative, it comes from the Latin word palliare, which means to cloak or to care for. And it really refers to the caring of suffering. And back in 1980, the World Health Organization defined palliative care in exactly that way, that we're an interdisciplinary team that attends to the many domains of suffering that people and their families and their medical care teams experience when they're going through a loss. So we treat physical suffering like cancer pain or shortness of breath that comes with heart failure. And we also treat emotional and spiritual distress that come with being very sick, being very uncertain about where things are going to go. And that's why our team needs to have many disciplines, because no one person can attend to all those domains of suffering and care for themselves. So the way palliative medicine is distinct from hospice is important for people to know, because I think a lot of people collapse those two terms. So in palliative medicine, you can be our patient at any age or any stage of your disease. So you may very well be someone that we're doing a bone marrow transplant on, and we expect you will fully recover from that. But during that process, the treatment itself causes pain, it causes mouth sores, it can cause feelings of deep sorrow for people that need to be in the hospital for a very long time. And so even though we expect to cure you, you can still be cared for and supported by a palliative care team. And we can also care for you right alongside all of the other treatments that might be given, even if cure is not the intent. So for example, I care for a lot of patients with end-stage cancer who may still be getting chemotherapy, or heart failure patients who are on multiple advanced medications through IVs, and we still walk alongside them and their families and their care teams for as long as that will be. Whereas in hospice, that's generally the point where we transition you from palliative care to hospice, and we're no longer doing those advanced treatments for cancer or heart failure or whatever the disease might be. Instead, we're really focused on helping you to feel the best you can and to have the best quality of life possible for as long as that may be, without focusing our efforts on treating the disease.
Right. So it sounds like palliative, or that hospice is part of palliative care, but palliative care is more than hospice.
Exactly. Yeah. I think of hospice as a type of palliative care that people can receive in the last 6 months of life. Yeah. But palliative care is not hospice. Exactly right.
Right. And it sounds like the connecting thread in there, where that overlaps with the work that I do, is there is pain that can't be fixed or cured. And even in some cases, that broader description of palliative care, where we do expect somebody to recover or be cured from their illness, but we need
Mm-hmm.
to address the fact that it really sucks right now on a lot
Exactly.
of different levels. And that's something that I really value in that palliative approach to suffering is there's some shit we can't fix, and let's just
Exactly.
open our eyes to it and tell the truth about how hard this is. And I feel like the folks who specialize in palliative care and palliative medicine, like they are willing to keep their eyes open to the hard reality in a way that even some other medical professions don't do. So let's dive into that for a second, because I think this is a really cool because I like talking about hard things. But what are some of the kinds of grief that you're exposed to sort of on a regular basis in your work and in your practice?
So that's such a great question, because I think right now there's a lot more focus on grief and suffering of frontline healthcare workers, but we have always faced that.
Yeah.
The pandemic is shining a light on it, but the truth is we've always faced it. And we haven't always been equipped in our educations to normalize that. So many of us hide it, and we suffer even more from it. So to give you some examples, I think a lot of physicians and nurses suffer greatly when they feel unable to stop some of the treatments that they think are really not going to help a patient, but the patient or family is insisting on it. Mm-hmm. So even aside from witnessing people die, even despite our best efforts to save them, I think it's the witnessing of suffering that really causes grief to many of us. And that could be somebody in intractable physical pain. It could be somebody very resistant to hearing the truth of their disease. It could be grieving our own inability to be truly honest and to sit there with someone despite whatever layers of discomfort might be in that conversation. And I think truly, certainly seeing people die, participating in code blues or resuscitation efforts that are unsuccessful, and participating in procedures effort that we know at some level is not going to help, and grieving our inability to have a conversation about that. I think many of us also grieve the fact that our grieving is something we must keep to ourselves, that there really isn't a support structure in our training or in many of our professions. Perhaps only at select places does that exist, but we're asked to kind of keep our emotions and our sorrows in whatever form they may take, keep it to yourself. And that is very much the message we get in training. So we walk into these situations as new attending physicians, for example, and we don't have the tools. And we don't even know that we're grieving sometimes.
Yeah. And that's that whole piece about how the medical profession as a whole handles or doesn't handle grief is something that I want to get into a little bit later, because let's pull back a little bit to, and you named a lot of kinds of losses and a lot of kinds of grief. And I think we've got this weird thing in this culture where we both overgeneralize and flatten our understanding of what grief is, right? Like, so grief is only related to death. And then if somebody says, well, no, I have grief over this thing over here, and then we say, like, that's not as bad as a death. So I really
totally
like about a whole, either a spectrum or a continuum of loss, and a spectrum and a continuum of grief. And you named so many important losses and aspects of grief that somebody who works in the medical profession, specifically in palliative care, might be facing. And there were a couple of questions and comments about that. And so some of the things you said were, there's the kind of obvious one, the grief that you have when a patient dies, because people die. And people die in your profession a lot of the time, right? It's sort of
a lot.
Right. And also somebody else brought up, like, we want to give people a good death, and that's not always possible. And I love that comment as well, that there's the grief for medical providers when we do the best, because I'm not one of the providers, but you do the best you can to provide comfort and to provide treatment and to make end of life as graceful and tender as possible. And that is not always possible. And as you said, like, that was a reality before the pandemic. But let's jump into the pandemic just for a second and maybe talk about, how have you seen some of those elements of grief that you see in your practice change or shift as a result of the pandemic itself?
So I think especially in the ICUs where I work a lot with the ICU physicians, we actually see every patient who comes into the ICU who has COVID. So we're working right alongside
The palliative care
them.
team does.
Yep.
Gotcha.
At our institution. And I think that's really great because we can help support the team and the family from day one. And we have an ongoing series of conversations with them about care goals as the patient's body declares whether it's going to survive or whether now is the time to transition to comfort care. So one real benefit of having those ongoing discussions is that I can also attend to the grief of my colleagues. I would say about 50% of what I do actually is supporting the medical team and the nursing staff. The reason being, many of us, including myself in my residency and my medical school training, we don't know how to confront grief. We don't know what it even looks like. Many of us confuse grief with depression. And so as I'm watching my colleagues and talking to them offline, I see that some of the forms of grief are definitely related to not being able to save everybody, trying really hard to be the superhero and feeling like you're a failure when you can't save the person, struggling with how to talk about newly delicate things like whether or not somebody should be on a ventilator, and having the family wonder, is that because you're trying to ration? So people are really kind of experiencing a lot of anxiety and grieving the new contours of their job and expectations of them. And I think right alongside that, there's a tremendous amount of anxiety about getting exposed themselves to COVID, not being able to fulfill their roles if they are infected, and a lot of anxiety about, will I give this to my family? How can I do my job and protect my family? If I need to stay elsewhere, I am missing the support system that I'm used to. And so where do I go? What's the space for me to grieve and to talk about all of this?
Yeah.
And I think there's so much anxiety, anticipatory grief going on. But it's not really the sort of thing I've ever been successful debriefing in a group. It's often the one-on-one conversations or the passing comments that someone might make that I then pick up on and explore either then or later. Because I think, again, grieving together or acknowledging your feelings together is not really something, at least in my medical training and in many of my colleagues' training, that was not something we did.
Yeah.
And when we did it, it felt awkward.
Yes.
And so it's this interesting thing where it's hammered into us, your feelings are your own. And even when attempts are made to have more of a support group or discussion between peers, it doesn't always work.
So when we talk about the whole cultural challenge around grief and how the ways that we normally talk about grief are as a disorder or pathology, just
Yep.
You're not being positive enough, look on the
Oh,
bright
yeah.
side, all of those things. That's like the wider cultural picture, right?
Yep.
And we often look to the medical profession to tell us, like, what are we supposed to do about this stuff? And one of the things that I do when I'm doing clinical trainings is I talk about sort of trickle down pathology.
Yep.
The medical profession is talking about grief as a disorder, something to get through quickly so that you go back to normal life and be happy again, or some shameful thing that we don't talk about. They might have a little bit more nuance, right? Because not everybody in the medical profession is clueless about grief. There are some amazing, amazing people in the medical profession who know about grief.
Absolutely.
Even if you're speaking about it with a little bit more nuance, I think what the general public hears is grief is bad.
Yes.
Right? Put that behind you as quickly as possible. And it's in the ways that we talk about it as a medical community. And it's also in the ways that we walk that talk as professionals, right? Like if you don't see your medical providers as human, if you don't see them as having a human response to the pain in front of them, we still have a model where we look up to our medical professionals as the role models. And so like the rabbit holes that we can get into around why it matters that not only does the medical profession talk openly about grief in general, but also find a way to talk openly together about their own grief. Like this has real world implications far outside the medical world.
Oh,
So
absolutely.
let's talk about that for a minute. I love what you said there, is that I have much better success one-on-one than I do in groups. And, first there's like, there are institutional constraints, right? Like there is so much work to begin again, even in the best of times. And we're certainly in this pandemic, not in the best of times, but in the best of times, there's so much going on in the medical world from minute to minute and patient to patient. You don't really have time to sort of stop and debrief and have a deep conversation about how you're feeling about this. That's just not logistically possible.
Exactly.
But I love what you mentioned there. Like you know what to listen for.
Yes.
You know what to watch for. And so when we turn our attention and we start looking for clues, we see them everywhere. So to be able to see this person said this about that last interaction, and I'm going to follow up with them and talk with them about it. Like that, that ability and that willingness to create space for others, even if they haven't yet asked for it.
Yeah.
That's a really powerful skill. Yeah.
And it's something that, when you start to tune into it, you see it everywhere.
Yeah.
You can hear it in the voices of residents that ask you for a consult. You can see it in their faces. Yes. You can see it when someone calls me for a consult to help them, especially with dealing with a family or a patient's care goals and what they really want for themselves. You can kind of, as they tell the story, you can see where their grief is. And some of it's directed towards themselves and their inability to have these discussions. Yeah. And they're trying again and again and again and getting more and more frustrated before calling. And it's always, people go on about 5 to 7 minutes when they call me to tell me a story about what they need help with and what attempts they've made to try to rectify the situation. And it's in those 5 to 7 minutes that you can really hear people grappling with emotion. And that's when I can say, this sounds like it's been a really tough case. I'm happy to see this patient, but I think we should maybe sit down and debrief how you're doing.
Yeah, I love it. So somebody made a comment on this idea about creating enough empty space for the truth to arise. And that's what you're describing, right? Because we're so accustomed to keeping our emotional cards close to our chests, right?
Yeah.
And again, maybe sometimes even more so in the medical community, where you are not supposed to have feelings. You signed up for this, no feelings, right? And so if we're in a profession where it's not okay to tell the truth, you don't want to tell the truth. And so having people who are willing to say, I see you, and it is okay in this interaction, in this space, it is okay to tell me the truth of your experience. And putting that welcome out for people. I think that's one of the things that we do here, especially with things like our Perfectly Normal social media campaign, where we have those posts that say, not wanting to get rid of their clothing for 2 years after your person dies is perfectly normal, right?
Yep.
People think that they're weird. They don't want to talk about it. And if we go first, then it makes it easier. And it sounds like that's the environment that you create for your students and your colleagues, is to say, I'm going to go first. I'm going to make a guess here, which is very different than that sort of unsolicited advice, even as a teacher, right?
Yeah.
So like, you're feeling sad about this case, and let me tell you how you should deal with that. Like, that's not what you're like. We don't have just those two options where like, I'm just going to let you suffer in silence because you shouldn't have feelings, or I'm going to tell you how you feel and how you should deal with it. And there's that middle ground there where it sounds like you can do this really elegant thing where you say, it sounds like this has been a really challenging time for you, and I would love to set some time aside with you to talk about how tough this is, and just talk about the reality of being human in a profession that breaks your heart over and over and over.
Yeah, and you can get used to what you see.
Yeah.
And I am reminded of how much grief I hold when I have a medical student rotate with me. And they'll watch these meetings, or they'll see people in excruciating pain that we have to help alleviate. And they'll say to me, how do you do this every day? Because even though they're medical students and they've been exposed to suffering, once they're on a palliative care rotation for a month, it puts things in a very different perspective for them. Yeah. And they're forced to confront things that many of the medical school curriculums don't really prepare them for. They don't prepare them for feelings of grief and loss when a patient dies. They don't normalize those feelings either. So when they rotate on my service, even I am reminded that what I do on a daily basis is not normal.
Right.
And so and to be told that is always a surprise, but it always brings up feelings.
Yeah.
It's almost like having the students who ask me that allows me to actually acknowledge what I am feeling about everything we're seeing.
Yeah. That's an interesting, like, doubling up of that, right?
Yeah.
You do become accustomed to this work. Whenever I open a new writing your grief course, or we bring in new moderators to train to work in that course, they're like, how do you listen to this many every single day? And I'm like, oh yeah, right. Like, you can get acclimated to suffering.
Yes.
And
absolutely.
That's not the same as having a callus. Sometimes in my training sessions with my facilitators and my clinicians, I talk about that difference between emotional and intellectual empathy.
Yeah.
Right? And that's a really important distinction to make. So super oversimplified, but emotional empathy is like you're really feeling with the person, and that.
Yep.
Like, and intellectual empathy is like you're feeling it, but you're also feeling it from a distance within which you can show up and be present and not lose yourself. And that sort of intellectual, and that's not a bad thing, it's a really good thing if you have to do this work, that intellectual empathy is what allows you to show up and do the work over and over and over again and not get consumed by it always. Sometimes we do get consumed by it sometimes, but so I love that you talk about that, like that. I think that we can use intellectual in a different capacity, in a different way here. It's like, I think as students of this stuff, when we're reading about it and we're learning about it, this is true for therapists as well as it sounds like medical providers, we think we've got this.
Yeah.
Right? Like, I know what that's going to look like. I know what it's like to sit with somebody who's, X, Y, and Z, and then you do it and you do it again and you do it again. And there is something so visceral about that can't be conveyed in a handbook.
Yeah, definitely not.
And the shock of that is really important to normalize and to talk about.
Of course. Yeah. You're dead on. That was an interesting choice of words. You're spot on.
Words are so tricky.
Exactly.
So we know how we would love to have the medical profession talk about grief and loss, because we've just been talking about that. And one of the questions that you and I discussed yesterday when we were talking about where we wanted to go is like, we know what the ideal is, right? You're working towards that goal. You're helping new students understand that grief is a reality in this work, and we need to find better ways to talk about it and talk about it at all. But how do you see the medical profession expect doctors and nurses and social workers and EMTs? What's the expectation, whether that's spoken or an unspoken rule of medical fight club? How are you supposed to handle the death and suffering that you see as a medical professional?
So, it's interesting. I was thinking about this yesterday. I was asking myself, was there ever a session, either a small group session or a lecture or something about this topic? I do not remember one in medical school or in residency. I think there were vague mentions of the fact that death and dying occur. We all know it will. But a lot of the focus was on how do you support a patient and family through that? Yeah. There was next to no attention about how we experience and process that. I do think there's a little more attention now to burnout and how the continual witnessing of death and dying and suffering that you're not equipped to really handle because the training doesn't help you do it. That can lead to burnout. But burnout is different from grief.
Yes.
It's different from sorrow. It's different from having human emotions. Mm-hmm. And so those are things I was never instructed on or given a curriculum around or even told it's okay to feel what you're feeling. Instead, I distinctly remember in my residency, I had a really hard loss of a patient. This was my intern year, my first year of residency. And I tried to talk about it with my attending physician. And I cried. And I was really upset. And she went to my residency program directors and said that I was too emotional.
Yeah.
So I was actually penalized for trying to seek support and trying to share my grief with someone much more experienced who I thought might have words of advice to offer, and who instead basically categorized me as something that I was not.
Yeah.
And
Well,
drew
shamed you for being human.
exactly. And it drew this binary that you can either be the stoic doctor or the emotional wreck.
Yeah.
You cannot be emotional and tender and be a doctor. And so I learned my lesson. And from that point on, I didn't speak to anybody with a role in my training at all.
Yeah.
My co-residents and I would occasionally debrief with each other, but even there, it was very much maintaining the face of success, maintaining a certain confidence. It was very performative. And I think there's a lot about doctoring that is ultimately performative. And a lot of that performance means not letting people in on how you are feeling. And that's, I think, ultimately really toxic, because I do think
toxic.
And it came back to bite me in the ass. I had so much grief I was carrying around in residency, and I started to shame myself for feeling sad about patient losses. I would tell myself, you shouldn't do this. You're a doctor. Get it together.
Yeah.
And that self-talk and external set of expectations, I think both ultimately led me to grieve kind of who I am at my core, which is someone who's always been a writer, always been very in tune with her emotions, and I'd always thought that would be useful in patient care.
Yeah.
And instead I was given the message that it was not only not useful, but that it made me unprofessional.
Yeah. And that connection between those two choices, right? Emotional wreck and therefore unprofessional and not competent, or stoic automaton who knows what they're doing, and that shaming.
Total shaming.
It's interesting that you say, you there wasn't anything in the curriculum in med school about that, and it's like, but so much of medicine is suffering, right? Like, how can you not talk about having a human response to that? And in the clinical fields, this is one of the things that I rail about a lot. In most clinical grad school programs, to become a therapist, if you get a unit about it at all, it's death, dying, and bereavement, which are
altogether
not the same things, not even close, right? Like, and grief is not the same as dying, and like what you. And, if you talk about grief at all, it's lumped in with death and dying and bereavement. Nobody bereavement. And it's such a bizarre oversight when you think about every single person who walks through your door as a therapist is carrying grief of some kind, or they would not be there.
Yep.
And yet when we train clinicians, and it sounds like when we train medical providers, we're not talking about grief as a normal thing. We're talking about it, if we talk about it at all, we talk about it as a pathology. We talk about it as something to be ashamed of and something to hide, whether that is as a medical professional or as a clinician looking at your clients, right?
Yep.
If they are still sad 6 weeks after their sister was killed, there's something wrong.
If
they're not happy and looking on the bright side 4 months after their baby died, there's something wrong, right? Like this deep, deep pathology of what it means to be human. And then to think about, like, as you described that, like that indoctrination away from being human that you described in the medical process, it's like, and then we wonder why doctors and nurses have such high rates of drug addiction, suicidality. The things that we see in the medical profession are things that we see in the wider population as well, of course. When you lie about your own truth to hide your emotions, for many reasons, but what we're talking about is because it's not professionally acceptable to be human. When you are forced to lie about your own truth, it doesn't go away. It comes out in other ways. It
absolutely
in addiction and suicidality and depression and isolation and interpersonal violence, right? Like, there is a massive problem in denying grief in any profession, but in the medical profession, like, that's just cruel. And I love what you're doing, Sunita, which is to not only reach out to your colleagues and your allies, but also to sort of steward and shepherd new students coming up through the medical profession to get them started off. Like, start them off crying so they can keep crying.
Absolutely. And I think, one thing that kind of saved me was my writing.
Mm-hmm.
And I kept a journal when I was in residency, and I would just write down phrases or images or conversations that would come up on a daily basis. And I went back to that when I was writing my book.
Mm-hmm.
And that was an interesting experience because just from reading sometimes just a couple phrases, I knew exactly what situation I was talking about, and all of the emotions came back. And even at a distance of years, they still felt like they were right there with me, that I hadn't put them anywhere.
Yeah.
And so where I put them was on the page.
Yes. I love that with that sort of, I think about, so I have a very good brain library. I think, like, I don't do anything to make sure that, like, when I read, a snippet or I see somebody's icon on social media, I'm like, all of that information flows back for me too, because I'm privileged to be able to read a lot of stories from grieving people through the Writing Your Grief courses. And I know their stories, and I know the name of the person they lost and when it was and who's been there for them and who hasn't. And when I just see their name, I say, oh yeah, like, this is Emily and her son's Jesse, and like go through all of the things. And it's like, there is some part, it sounds like you and I have similar brain librarians.
Yes.
Who, like, you have that one little window through a photograph or a scrap of a story or something, and it unlocks the room where that person lives in your mind and heart. And writing does that, right? Like, it's
absolutely
like that, those stories still stay with you. And I think that's true whether you acknowledge them or not, right? Like, if we just want to link back to what we were just saying about unspoken grief leads to more suffering, like those rooms of poignancy and those rooms of connection, the pain and suffering that you've witnessed become part of you is still part of you, whether you acknowledge it there or not.
Exactly.
And what I love about you as a writer is that, well, I love everything about you, but what I love about you as a writer is you wrote this book, That Good Night, in order to tell the truth about your own experience and about what you see in the medical profession. It's sort of this this call to action for people in the medical community to go, yeah, you're right, actually, like, I really want to talk about this. And so there's so many levels in the book for you. One, it's one way for you to tell your own truth.
Yeah.
And also, when we tell the truth of our own experience, we encourage and allow others to speak their own truth. So it's a very revolutionary act to tell the truth about your own experience. So talk to us about that, even more about that process of writing your book and what it's for. And
so I always loved and kind of revered reading and writing way before I went to medical school. I used to sleep with books under my pillow when I was in elementary school because I wanted to be as good of a writer as like Beverly Cleary and Judy Blume and whoever wrote the Sweet Valley Twins books. Like, that was the stuff I was reading. And I loved it, and I dog-eared it, and I was like, I want to be a writer just like them. And that sort of continued throughout my education, throughout my life. If I was conflicted about something, I would journal about it. Mm-hmm. If I was any emotion about something, I would absolutely go to my page. Sometimes I would just tell myself stories out loud. And when it came to medical school, when I got there, I became really obsessed with the things we were verbalizing and the things we weren't verbalizing. And a lot of what we didn't verbalize was what we've been talking about. How to talk to patients about suffering, how to witness suffering, how to deal with your own feelings about suffering so that you can go on to the next patient. Where you put those complicated feelings, do you have a ritual for them? And so writing became my ritual. And I think with grief or any form of suffering we're experiencing, having a ritual can really give us a place to work out and to put the complex feelings that we have about whatever it is that we're experiencing. And because I was obsessed with language, I really started to pay attention, especially in residency, to the things we were saying to patients and the things we weren't saying. Mm-hmm. So if a patient described themselves as a fighter who wanted everything done, in residency, I would just say, Okay, because I didn't have the tools to really excavate what that language meant. And it was in my fellowship that I really started to get a grasp of asking people, tell me what fighting means. When you envision us doing everything for you, what does that look like? What's
Such
the
a
image in your
good
mind?
question. That is such a good question because, like, for words mean different things to different people, right?
Absolutely.
And when somebody says, "I want everything done," tell me what that means, right? There's
Yep.
I don't know if you know Chanel Reynolds, who is a wonderful friend of mine, and she started an organization called Get Your Shit Together to help people do
That's
their end
great.
of life documents, right? So their living wills and their advanced directives. And she always says, like, when you say, "I don't want to be," excuse the language, "I don't want to be a vegetable," what
Yeah,
does that mean? Because it
exactly.
means different things for different people. So, like, being able to know that you can't make a guess about what somebody means by what they say, and that it's okay to ask, like, paint me
Yep.
a picture of that. I love that. Okay,
And
keep going.
and we all kind of read from the same script. That's what I kind of started to observe, bringing my writerly self to my patient interactions.
Yeah.
Everyone says they're a fighter. Everyone said that they were waiting for, not everyone, but a lot of people said they were waiting miracles. And so part of why I wanted to write my book was because I didn't have a book like that to turn to when I was wrestling with these questions. And regardless of whether someone chooses to be a palliative care doctor or not, wrestling with those questions, I think, is part and parcel of practicing medicine, because those questions are going to, or those statements, the use of that language is going to come up. So how do we reckon with that? How do we place the words people use in the context of the stories they tell themselves about themselves and illness, about who they want to be, and the stories they tell us about what they're willing to endure to get there? And so I wrote the book in part because, honestly, in a way, it was insisting itself to me. It was pushing against my very bones. And the book is a lot about what it means to go into palliative care, the decisions I had to make along the way, but it's also very much about where I came from as a person, being born to Indian immigrants who were both came from extreme poverty in India in the post-independence era, how they made their lives here and how they depended so much on God and faith. And so it's the intertwining of the spiritual and the medical and the linguistic that's really what the book was about. And I wrote it in part to understand myself. Why did I choose to do this? Because that I asked myself that a fair amount on frustrating days.
Yeah, I feel you.
Say, these are normal things to grapple with. And there is a way to grapple with them that in which you can stay true to yourself and still be a good care provider.
Yeah, and I think the one of the important pieces in there is that the struggle is normal. That
Yes,
grappling with these questions is part of the point of practice, right? Like with any
exactly.
kind of practice, that you're to normalize that you're not always going to think that this profession was the greatest choice,
Yep.
right? And that you're going to wonder 8 million times a day sometimes if you're cut out for this.
Yes,
That those questions make you a better provider, right?
exactly.
Allowing yourself to have those questions makes you a better provider because it means that you're listening to yourself, right?
Exactly. And
Yeah.
you're letting what comes up, you're letting it come up.
Mm-hmm.
And if writing or talking with somebody or going to therapy, if that's whatever your ritual is, the safe place you can go to ask those questions and explore them, I think that's something, if I'd been taught that in medical school, I think my colleagues and I would have made it through less kind of picked away at, less damaged, not having to compromise who we are
Mm-hmm.
in our quest to be a doctor.
Yes. Yeah. And that's, I mean, that's who you want at your bedside, right? That's who you want on your team. Somebody who is willing to feel what it is to be human and show up
Yeah,
anyway. And the way that you
exactly.
get there is by having questions. And one thing I want to clarify here, for folks, is when we talk about having a ritual around these questions and around these emotions and these feelings and these responses to the pain around us, a ritual isn't meant to take away from you. It's meant to
Yes,
give it a container to exist. And I think
Exactly.
because we're so grief avoidant in this culture, we think like, get the ritual right and you won't be in pain. Get the ceremony
Yeah.
right, get the practice down, and you won't feel this way anymore. And that's a real diss to ritual.
Totally.
It's a real disservice
Exactly.
to ritual, because it's, the point of ritual is, or ceremony, is to not make the thing go away, but to give the thing sacred space to exist.
That's a
Yeah.
beautiful way of putting it, really. And I think that's the other problem with grief and with expressing emotions in medicine, and maybe in our wider culture too. We're not expected to emote.
Yeah.
Emoting is a very vulnerable act. Yeah, exactly. Like and I think social media may have contributed to this. We're just expected to put forth what is socially acceptable and what other people can handle.
Yeah.
And so where do we, whether we're healthcare providers or not, where do we go to make sense of our emotions? Because something I really do believe is if we don't process them, then they show up somewhere in our physical existence.
Mm-hmm. Right. Yeah. And in our interpersonal existence, and all of these, right, that unspoken pain, unspoken questions go away, they find a way to speak. And,
Yeah.
we're hearing a lot about, so pandemic aside, we're hearing a lot about epidemics of loneliness as a
Oh, yeah.
health issue, right? And we talk about this a lot in my communities and on my social media channels about, like, why are people lonely? Well, people are lonely because they can't connect. That's sort of a dub,
Yeah.
but stick with me here. So loneliness comes from a lack of connection. And if you go to somebody and you say, I'm having a really hard time, can we talk about it? And they come back with like, buck up, little camper, put a
Yeah.
smile on your face, look on the bright side. You don't have
Look
it as
on the
bad as
bright side.
you don't have it as bad as somebody else. That doesn't remove that person's pain. It tells them, I'm going to stop talking to you about it.
That's exactly right.
If we can't go to each other, if we can't connect with each other, then that creates loneliness.
Absolutely.
And as
it
some studies have been showing that loneliness is the bigger public health issue than smoking. Right.
I completely agree. I think our former Surgeon General, Vivek Murthy, talked a lot about this, and I think he's completely right. We are connected electronically, but what it means to connect as human beings, I think, has fundamentally changed. And how do we restore that? I remember reading an article. I think it was an opinion piece in the New York Times. It must have been like 10 years ago. But this person talked about how in eras past, we would explore our emotions with those around us. And now I've at least certainly experienced what this author was talking about, whereas if I talk to friends about something very trying that I'm going through, a lot of times I will get the response, are you talking to a therapist?
Yeah. Let's punt
it to someone else. Exactly. And I think, at least, and that writer, I think, was right on in saying the vulnerability we need to extend as humans to connect. In eras past, that was received by someone. But now we have to pay other people to explore emotions. And I can totally see how it might be a generalization and a simplification, but it definitely kind of brought up something in me that if part of some of our ways of connecting comes from emotional bruising or an experience that we want to find comfort and validity in from someone who knows us, the punting to a professional can be a way of feeling like, I can't handle your emotions.
Exactly. That's a really clear message. Like, I'm having really hard time. Have you tried talking to somebody?
Yeah,
I'm trying
exactly.
to talk to somebody right now.
Right now, exactly.
Right? And then of course we have the extra step here that many clinicians, even those who specialize in grief, are coming from a deeply pathologized foundation, and they're not going to be helpful anyway. But the reason that I was making faces at the whole, there was a golden era where we talked to each other and our emotions were welcomed. Like, I don't know that golden era existed. I think one of the things here is that the priest punt to a therapist or punt to a professional thing that we've seen for the last several decades is a change, right? It used to be you either kept your shit to yourself,
exactly,
or you talked to your priest or your rabbi, and now it's like, keep your shit to yourself or talk to a therapist.
Exactly.
I think it's really easy to romanticize not only other eras, but also other cultures, obviously with cultural appropriation, but to say like, there was some glorious time in our distant past where we all came together and talked about our feelings and honored it. I think we'd have to reach pretty far past. I mean, if we look at the 50s, where, you know, certainly my parents' generation, you do not talk about your personal life. So
yeah,
my grandfather, his mom died when he was a baby.
wow.
I don't know the whole story, but all of his older sisters blamed him, being an 18-month-old baby, for his mom's death.
Oh, wow.
And so just shamed him. And so there are these like generations of unspoken grief and trauma in my family and in many people's families. So I think if we're going to say there was a time when we all talked about this better, we got to go back, I mean, millennia.
Yep.
Or probably to like ancient Crete, not Crete, right? Like really women-centered, focused, whole other thing we could talk about another time.
Exactly. Right? I apologize for moving around so much. My phone is low on battery, so I had to find my charger. Hold on one sec.
Well, we've got 13 minutes left, so you go do that, and I'm going to rail about glorious times that did not exist when we did get better. But I do think one of the things that happens now is, you know, we're so uncomfortable in the face of somebody else's grief, and we feel so awkward, and we don't like that awkwardness. And so we come to, you should talk to somebody. And the unfortunate subtext there, sometimes it's not subtext, sometimes it's obvious, is I don't want to deal with this right now, so please take it somewhere else. And that's how I'm going to help you, is by telling you to go somewhere else. And, you know, we'll go into good intentions just for a sec here while you get your charger all set. And I do think that many people, some people are jerks, I know, but many people do have good intentions, and they say those things because they're trying to be helpful. And again, I come back to, this is why it's so important to talk about the ways that we come to grief as individuals, as professionals, because not only is it doing damage if we don't have our own stories told, we're not doing a service to the people who want to be supportive, because they're swimming in that same toxic misinformation that says your job as a support person is to cheer somebody up, tell them to go talk to somebody, basically put their messy emotions behind them so that you can go back to talking about something else, and quit getting in my face with all your sadness. And, you know, said, of course, with the utmost love and affection. And this is why this stuff is so important. And this is why we write books. And this is why we do Instagram Live. And this is why we do podcasts and media, and talk to our friends and our allies and our colleagues about all of this awkward, deep stuff, because it's important and it matters.
It matters. Yeah. This is the stuff that makes us human.
Yeah.
You know, these emotions, the experiences and our reactions to them, that, like, without that, what would we be? Without supporting each other through that, what would we be?
Well, you know, I think that's a really interesting question, because I think that some people would look at that and say, that's the ideal person. That's the ideal doctor, to not have any emotional response to the pain that they see, to sort of remove all of that messy, tricky human being, and just be a professional. And for some people, I do actually think that the removal of all human emotion is a goal.
Yep.
And I think that points to this pretty archaic idea of perfection and not being messy and things being under control. And there is a place where you can rise above everything and not feel stuff, and that feels interesting to some people. Like, I want that. For those of us who are like, that sounds like a fucking nightmare, maybe not the goal. But I do think that that's one of the things that we're up against in the medical profession, and I include therapists in that medical profession, this idea that there's a separation of the heart and the mind, and the heart has to lose. If we're going to be held up as intellectuals, as professionals, then it has to be a win-lose situation, and the mind has to lose. The mind has to win and the heart has to lose.
Yeah.
And I think that putting the mind as the North Star to which we aspire is a narrative that's running underneath a lot of things that makes us silence that heart and that humanity. And the work here is to understand that we need both right?
Yes.
I don't want my doctor breaking down sobbing in the treatment room with me, and then I feel like I have to take care of them. I don't want
Oh
that.
yeah.
And I also don't want my person just like sitting there reading like a robot from a thing and not like telling me, right? Like, we are humans. Can we be human together? And I need your expertise and I need your solidity, right? There's a great book called A General Theory of Love. Do you know that one, Sunita?
No.
One of my absolute favorite books. It's probably 15 years old now, but it's about neurobiology, trauma, and attachment.
Oh, interesting.
It's such a great book. But it's written by 3 psychiatrists, and what they say is that when you're sitting with a therapist, it doesn't matter what school of thought they come from, whether they're Jungian or whatever. What matters is that their brain waves are more stable than yours at the time that you're sitting together.
Interesting.
So what actually works for our neurobiology is a calm presence.
Yeah.
Right.
But I have that calm presence. I mean, certainly I've been in situations where family members are screaming at each other, the patient looks horrible, or I've been the one to call codes or start chest compressions on somebody.
Mm-hmm.
You do have to be that rock.
Yes.
To be that rock means that you have to take care of yourself so you can be that rock.
Yeah.
Because I think there's a difference between detachment and being humanly engaged.
Yes.
With the patients that you're taking care of and the families that you're taking care of. And I think for authentic human engagement, again, I don't think that means sobbing when you see somebody, but I do think it allows for that emotion to influence an interaction while also being a clue to the practitioner that maybe I need to do a little extra self-care.
Yeah.
I think
Absolutely.
part of what enables me to be a rock most of the time, not all of the time, but is that I have a great palliative care team.
Yes.
The worker is fantastic, and he's a therapist on the side.
Mm-hmm.
So he brings a lot of the mindfulness and the grounded spirit to our team, and he's the one that usually helps us process a lot. My nurse practitioner is very similar, very fabulous, and the three of us together, I think, can be rocks for patients. Yes. Because we're rocks for each other.
I love that. And that's like, this is exactly what we're talking about, right? Is that you have to be able to be in a space where you can have your own loss acknowledged so that you can show up and be present in the places that you need to.
Exactly.
Right? And it's that acknowledgement. And my guess is that, you and your team don't have to have 3-hour long sessions where you're sobbing and emoting and like all of this stuff, but that acknowledgement of each other is powerful medicine, right? Like,
exactly.
I know and thinking about like that self-care stuff, right? Like, there are days when I will read somebody's story and it will wreck me for the day. And when that happens, I know, oh, your tanks are running low, because it doesn't usually take you a full 24 hours to recover from reading a story.
Yeah. And
being able to have that team of people to say, like, this story really got to me today, and I just need to acknowledge that this is what's happening, right? Yeah. That acknowledgement is so powerful.
Exactly. Sometimes just naming it and being brave enough to name it authentically, yep. That can be enough to kind of go on with your day.
Yeah.
Have exactly. A place to it. And if you don't have a team or a set of colleagues, again, that's where I really think having a ritual, and that ritual absolutely can include going to therapy and knowing that that is a space to really express yourself, to be held in that expression, and to learn tools to move through it when you're in the situation of taking care of another person. I was actually, after that whole thing happened in residency, I started going to see a therapist. And I was admittedly not a very good patient, because sometimes I would cancel when I was exhausted, or I just couldn't go because I was on call every third day. Mm-hmm. But one of the things we talked about was when you're in a situation where you're feeling something and you can't express it, what do you do?
Yeah.
And I now have this practice where I just put my hand around my wrist, mm-hmm. to remind myself that I am there with myself.
Yeah, nice.
Everything that's happening. I'm so glad she gave me that tool, because it really helped me in moments where, I felt that I was going to cry and would get in trouble for it, or moments where somebody was, being unkind to another person and I didn't know how to intervene, or times where I just started to grieve everything I'd given up to be a resident.
Yeah.
And wondered if it was worth it. And I would just I still do it. I put my hand around my wrist and I can just feel that I am there with myself.
Yeah.
And that's all I need.
Yeah. I love that. It's like this, it's a portable anchor.
Exactly. Right? That's a great way to put it.
It's not about talking yourself out of the emotion. It's about acknowledging the emotion, and acknowledging emotion seems like it's too simple. It won't do anything, but it is very, very powerful. So we've just got a minute or two left. And I want to make sure that people know where to find you and where to find your book before Instagram cuts us off. So yeah, tell everybody where to find you.
So you can find me at my Instagram handle at Sunita Puri MD. And I'm also on Twitter with that same handle. And then you can find my book. It's called That Good Night, Life and Medicine in the 11th Hour. And you can find it really anywhere books are sold. So online, on Amazon, on the websites of your favorite local independent bookstore. It's hard to say go get it from your local bookstore because so many of them are closed. But
lots of them are doing delivery.
Oh yeah,
Yeah.
Absolutely. So I would just say doing our part to support our independence in this time of crisis is a really, really wonderful thing we can do for them. But yeah, you can find it anywhere. It's now paperback, and it's in hardback and audio as well.
Okay.
And from readers, so if you read it and have something to say, no matter whether it's positive, negative, or both, I'd love to hear from you. And I hope it's a tool for healing for everybody.
Awesome. Thank you so much for being here, friends. So I'm gonna click the end button here, and Sunita and I are talking about doing a longer form conversation with some actual Q&A from folks. So stay tuned for announcements about that. All right.
Thank you, Megan. Thanks, everyone.
Bye, everybody.